in super depth of each aspect. But this is just hopefully will give you a flavor of where we are and some evidence behind using endosonography and all the techniques with that. All right. So endoscopic ultrasound combines endoscopy with ultrasound to provide superior images. If you look at the diagnostic aspect, that's what historically was used for EUS, largely for staging malignancies, and then came the linear EUS scope, allowing us to do EUS FNAs. And then part of diagnostic EUS, I would say now, which we are excited about, is portal hypertension evaluation. In terms of therapeutic EUS, fine needle injections, fiducial placement for oncology, draining abscesses, cavities, fluid collections, getting access to the biliary and pancreatic ductal systems, gallbladder drainage, cancer ablation, enteric anastomosis. So there are so many possibilities now. And what I've highlighted in red is sort of what I'm going to discuss today with all of you. All right, so if you think about upper EUS, the anatomy that's accessible via upper EUS includes, say, intrahepatic ducts, common bile duct, the gallbladder, that's the entire biliary tract pretty much, except the right intrahepatic, which can be challenging. The pancreatic collections in the pancreatic bed, the duct, the pancreatic duct, small bowel, and then vascular structures like gastric varices in the gastric lumen, the portal vein, as well as the IVC and hepatic vein. So what's transformed the field of EUS now, as we talk about interventional EUS, is these Lumen opposing metal stents, which has gained a lot of traction and excitement. There are various ones available in market with different abilities, right from the Boston Scientific created, the acquired Axios rather, created by Dr. Ben Moeller in California. And then Spaxis by Taiwan, Nagy by Taiwan, Plumber by MI Tech. Largely, if you think about the left two ones, they have better lumen opposing force, so they can be used for enteric anastomosis. But Nagy or Plumber can be largely used for draining of collections, I would say, peripancreatic or post-operative. And then now we have some biliary drainage stents available, which have these unique designs, and I've used these with good success. The Geobor by Taiwan, the BPE by MI Tech. So the advantage is they can be used for Hepatico Gastrostomy or Colidoco Deuteronostomies. So the advantage, as you see here, it's partially covered. So the uncovered portion can be inside the biliary ducts, enable it to be embedded in the biliary system. The covered section prevents bile leakage. And then you have this, this portion here at the other end, which prevents migration outside the enteric lumen. So these are designed specifically for this purpose. And all right, so we'll talk about endosonography in different aspects. So let's see, EUS oncology. I'll just touch upon how EUS can be relevant in cancer patients. This is a review article which I wrote about 3 years now, and this really highlights everything that endosonography can be done in oncology. A lot of this is experimental right now, but by and large, the backbone of our existence, which is diagnostic EUS for staging and FNAs, is what we largely use it for, and I'll talk about some other things now. So EUS guided fine needle aspiration, which is the most commonly performed EUS procedure. Various FNA needles are available in the market. The Cook has its EchoTip, Boston has its FNA needles, and just to highlight what it is basically, and here's just EUS view of a pancreatic mass, which you see here. I've used Doppler to ensure there are no intervening blood vessels. And what we perform now is EUS guided FNA. And what I'm showing here is a technique called fanning, where you use different angles to get inside the mass to enable you to sample different parts of the mass. In this patient, the path turned out to be pancreatic adenocarcinoma, which is the most common finding. I'll just highlight some other case just to show the importance of EUS-FNA, because not every mass is malignant or cancer. And, just to show you this case, 68-year-old female with atrial fibrillation, MGUS progressively increasing to multiple myeloma, status post stem cell transplant on immunotherapy, found to have a 2-centimeter lesion in the body of pancreas. And as you see on this cross-sectional imaging CT scan here, there's a mass in the middle of pancreas. And EUS performed showed a 1.6 by 1.6 centimeter mass, and EUS-guided FNA was performed. And turns out this is not your adenocarcinoma, but it was extramedullary plasmacytoma of the body of pancreas. So not every pancreatic mass is cancer and adenocarcinoma, just to highlight the importance of EUS-FNA in all patients with pancreatic masses, because sometimes you find neuroendocrine tumors, or as in this case, the finding. All right, so if you look at the efficacy of EUS-FNA, by and large, data shows more than 90% sensitivity and specificity. Pancreatic cancer, which is, as I said, the most common indication, pretty high sensitivity, generally in a good range above 80%. For mucosal and submucosal lesions, it drops down to 59%. And but if you use the newer needles, which I'll get to in a few slides, the sensitivity can go up to 87%. So these are the more challenging lesions to FNA. All right. EUS-FNA is a remarkably safe procedure, and adverse events noted in the series can be less than 1%. Acute pancreatitis, abdominal pain, fever, sedation-related issues occurring in, say, pancreatic masses, say 9 out of 254 in this particular series. So by and large, most patients do not have any problems, and it can be very safely performed in expert hands. All right. So now what we have are the new fine needle biopsy needles, and actually I've been using them for the last 3 to 4 years. And really, these are fantastic needles with newer designs, and each company has come up with its own sort of design, but they're all really equally good, I would say. I've used the Cook needles frequently in the past, and they've had excellent core samples available with them. And then you have the Boston Scientific with its Acquire needle, the Shark Core having its Covidian needle, and the Cook with its EcoTip Procore needle. So they have different designs at the tip, which enable a good tissue sample to be acquired. The only caveat, as I'm talking about these needles, is when I'm doing fine needle biopsy, I know usually the sample quality in my experience is better than FNA. But the only times I quite frankly nowadays use FNA needles is largely when you have difficult anatomy, or there are a lot of blood vessels, because these are very effective needles, but then there can be a risk of bleeding if you go through a bigger blood vessel compared to FNA needles. So therefore, if there are a lot of blood vessels, sometimes I switch to FNA needle just in the interest of safety. But by and large, these are my workhorse needles, which I use for most of my cases. All right. So if you compare EUS-FNB versus EUS-FNA, this is a systematic review and meta-analysis. Overall, higher specimen adequacy in these studies and lesser number of needle passes required for tissue sampling, as most of us who use these needles have experienced, I suppose. All right, so I'll just talk about an important study. This is an ASPRO study, which basically compared a 25 gauge EUS-FNA needle with a 20 gauge EUS-FNB needle, both actually manufactured by Cook. This is the EcoTip Procore versus the regular FNA needle. And this was a randomized controlled trial conducted in 13 US centers worldwide. 608 patients were enrolled from February 2015 to September 2016. Specimen processing was performed in a particular manner. Samples were collected in 3 vials, while 1 was for the first pass, while 2 for the second and third pass, and while 3 for any of the subsequent passes. They allowed the centers to sort of preserve the samples according to their local practice. Now, if you look at the data, technical success rate was basically almost similar between the 2 arms. The 20 gauge FNB needle, although flexible, you could encounter some cases in which the needle is unable to reach some difficult locations. This probably occur only in 4 out of 300 patients in the 20 gauge arm versus really 0 in the 25 gauge arm. The number of passes required was significantly, well, overall number of passes, 1 to 3 passes was more in the 20 gauge FNB arm. The fanning technique was used less actually in the FNB arm, and ROSE, which is rapid on-site pathology evaluation, was lesser in the FNB arm. Just to highlight that fanning is a technique, as I showed you earlier, which enables us to get even better samples. And therefore, the fact that less patients underwent fanning in the FNB arm means technically you would expect lesser yield. But let's look at the results further. So the quality of tissues was sufficient in the first arm. The first pass was equal, but when you come to 1 to 3 passes, significantly more patients in the FNB arm had better quality tissue. Now, as far as tissue cores was concerned, the yield was much better in the FNB arm. Immunohistochemistry could also be performed more in the FNB arm. All right. In terms of sensitivity for malignancy, higher in the FNB arm. Overall accuracy for malignancy was greater in the FNB arm, and accuracy for Bethesda classification was better. All right. So overall, the study concluded that 20 gauge FNB needle did sort of outperform the 25 gauge FNA needle in terms of histological yield and diagnostic accuracy in the pancreatic as well as non-pancreatic lesions. So just suggesting that the FNB needles, as in line with other studies, appear to be slightly superior. Again, this is not a huge difference, but for people who use and have done a lot of FNA and FNB, I think would concur and agree with the findings that FNB needles actually do provide sort of better tissue sample. All right, so moving on with the EUS guided celiac plexus neurolysis as part of oncology patients treatment. This is an outpatient procedure performed for patients with pancreatic cancers. Generally, a 22 gauge needle is used. You can use, well, there's a Cook needle available, which I have used before in the US, but it's not available in, I think, in India. Correct me if I'm wrong, the Cook team. But what we do is a mixture of 0.25% bupivacaine, which is a local anesthetic, with 98% alcohol. So the local anesthetic serves its anesthetic purpose, and alcohol is used for neurolysis of the celiac plexus nerves. So if you look at the data overall, if you look at all the studies available, there are various studies with different designs. I mean, there's either unilateral, bilateral, central. The active drug component was different in different studies. Follow-up was different. The outcome that they assessed was the visual analog scale. And if you see, most of the studies have shown significant improvement, but just to understand, these patients don't entirely 100% improve with neurolysis. So the pain scores improve. So now let's look at study 1. Improve from 6.6 down to 1.2 on visual analog scale. Again, study 2, similar, 6.2 down to 2.1. The other outcome assessed was visual analog scale score less than 3, was achieved in, say, about 70% in this study, 88% in another study. So that's roughly what you would expect. And these patients do well. The neurolysis takes the edge off. It allows you to reduce your opioid dosing, but wouldn't take away the pain completely. All right, so EUS guided radiofrequency ablation can be performed. There are devices available, StarMed from South Korea, the Habib catheter by Emcision. So just to illustrate, by our colleagues down south from Hyderabad, they show a case of insulinoma, which underwent successful EUS guided RFA with resolution of the tumor with improvement in symptoms. I've done this once before with good success, so this is an exciting option in those neuroendocrine tumors which are small in length, small in size. All right. So the other new development is the EUS guided vascular access, and as I outlined earlier, you have access to some of the vascular structures around the GI tract. It's interesting because historically we would always be trained to avoid blood vessels when you're doing EUS. But now with changes in approach, now we actually target the blood vessels and we actually gain access to the blood vessels to perform a therapeutic or a diagnostic testing. So just to highlight, this is a review I wrote recently, it should be out now, role of endoscopic ultrasound in assessing and management of portal hypertension. For anyone interested, feel free to email me, I can send it across. Okay, so when we look at patients with portal hypertension, as we understand, can be in non-cirrhotics as well. It can be from issues in heart, IVC, hepatic veins, the intrahepatic causes, or the prehepatic causes in the portal and the splenic vein. So if you look at intrahepatic issues, it can be either post-sinusoidal at the level of central vein, like veno-occlusive disease or central hyaline sclerosis, sinusoidal at the level of for cirrhosis patients, pre-sinusoidal in patients with schistosomiasis, early primary biliary cirrhosis, congenital hepatic fibrosis, sarcoidosis, etc. Now, if you do IR-guided hepatic vein pressure gradient measurement, it won't be accurate for post-sinusoidal or pre-sinusoidal cases. So these are the patients who you would prefer direct measurement. Okay, so just my Cook team just updated me that the celiac plexus neurolysis needle is actually available in India. So well, that's just to be corrected. All right, so moving forward, EUS guided portal pressure gradient measurement is hopefully going to be soon available. Just to illustrate, transgastric or transduodenal, you can gain access to the portal vein or the hepatic vein, which will enable you to measure pressures directly by the needle in situ. So this is better than HVPG because HVPG is an indirect measure, and direct portal pressure measurements would, be more superior in terms of obtaining the portal pressures. All right. So the initial animal studies have basically shown that this can be performed successfully. Technical success rate was in the range of 90 to 100%. One patient developed a complication, which was a subserosal hematoma. By and large, most animals did fine. In an animal study, the correlation between EUS guided pressure measurements was comparable to what was obtained by HVPG in the study. And what we have published now almost 3 years ago is the first human study for portal pressure measurement. I have a video which I've obtained from the study where basically in this study they included 28 patients and of various etiologies, bleeding risk with INR more than 1.2 in some patients, and then thrombocytopenia as well. And cirrhosis was actually in 19 of the 28 patients. So here they're showing the direct pressures that can be obtained by inserting the 25 gauge needle in the hepatic vein. And then next, you can look at the portal vein here and then get access to the portal vein and obtain pressures using a digital manometer in the portal vein. So now 3 pressures are generally obtained and to average out. All right. So in this case, the portosystemic gradient was 1.3. All right. So they compared the portal pressure measurements and findings with endoscopic findings. Patients who were felt to have high risk of cirrhosis had a higher portal pressure gradient, varices present, higher portal pressure gradient, portal hypertensive gastropathy was present, higher portal pressure gradient. They were feasible in 100% patients. 68% they got into the hepatic vein, 32% they got into the IVC, since hepatic vein was not easily accessed. Transgastric access to the portal vein in 86%, 14% transduodenal. And most importantly, now it's a diagnostic procedure. So the adverse events were not seen in any of these patients. So when you're using 25 gauge needles, you're going across the liver into the veins, the odds of bleeding are generally quite low. If you're using a 19 gauge needle and you're going into a major arterial structure, then there's a risk of bleeding. So in fact, I'm not outlined here, but there's another study in which in an animal model where they use a 19 gauge, 22 gauge and a 25 gauge needle, and they gained access to aorta and venous structures. And what they found was virtually never would there be a risk of significant bleeding if you use a 25 gauge needle in the venous structures or even the aorta. But when you start using larger bore needles, the 19 gauge needles, you can experience some bleeding risk. So for portal pressure measurements, what would be generally used is a 25 gauge needle. And to add to that, if you go across the liver, I think the risk of any complications is generally minimized. All right. So if you look at the etiology of portal pressure, portal hypertension, if you EUS guided portal pressure gradient could be applicable in virtually all these patients. And I can see the role in, newer portal hypertension therapies, say if you're using statins to effectively monitor portal pressures. You can tailor management, as you know, some patients, despite adequate beta blockers and variceal banding, may not achieve targeted pressures. So perhaps early tips in these patients may be a reasonable idea. Any patients undergoing EGD can, at the same setting, get EUS guided measurements of the portal pressures to further facilitate in management of the patients. So I think this is going to open a new field of endohepatology, and I'm quite excited about the prospects of the EUS guided pressure measurement. And actually just out there, much beyond, beyond what we can do now, this is EUS guided intrahepatic portosystemic shunt. Now, this is not performed in humans yet. And this is a study, a video which my mentor provided me from UCLA. This was performed at Johns Hopkins. And in an animal model, they gained access to the hepatic vein. And then from there into the portal vein, you see the hepatic vein up here, portal vein down here. And as you'll see, a guide wire was then advanced into the portal venous system, followed by placement of a fully covered metal stent. Now you see here, it's being placed across into the portal vein, right there, getting deployed. All right, and then the proximal end is in the hepatic vein, now as you see here. So right there, fluoroscopy. Okay. So I think if this is available in humans in future, I think it's an exciting prospect. Say you have an emergency bleeder in the middle of night, you can't control the bleeding. You could potentially put the EUS scope, get a stent across the hepatic vein into the portal vein, and perform the IPS procedure successfully. All right. So moving on for endohepatology, the EUS guided liver biopsy, which is now gaining a lot of popularity, is in this meta-analysis showing a diagnostic yield of almost 94% with an adverse event rate of 2.3%. Again, not major adverse events. Some patients can have subcapsular hematomas, as you can imagine, with liver biopsies, but by and large, a pretty safe technique, and can really be a one-stop shop where you basically do EGD, you do EUS, you can get portal pressures, you can do a liver biopsy at the same time. More convenient, I think, for the patients because there's no pain. This is all internal. So I think this can be an exciting option. All right. So moving on, let's talk about EUS guided drainage of any perienteral collections. So I'll just show you some cases. Routine patient, 28-year-old female with acute on chronic pancreatitis with a walled-off pancreatic collection, presenting with abdominal pain and fever. And under EUS examination, you see this large anechoic structure here, which is the walled-off pancreatic necrosis, or I think in this case more like pseudocyst. And right, so here we are deploying a lumen opposing metal stent under direct visualization with excellent drainage of contents. Sometimes I like to put double pigtail stents just so that the metal stents don't migrate. All right. Okay, 1 second. So in patients who sometimes can have large amount of necrotic debris, we've done a lot of these patients where patients can have a lot of necrotic material. And just to highlight, this is like a second session for a patient undergoing necrosectomy, where you have a lot of necrotic thick debris with pus pockets right there in the recesses. You can actually manually debride and take out all the necrotic material as shown here. Again, this is a completely different topic of discussion. We can go in more depth, but by and large, if you look at the current guidelines and all the recent data, EUS guided approaches with endoscopic necrosectomy has shown superior outcomes compared to some minimally invasive surgical techniques or open surgical necrosectomy. This largely because of lower risk of fissulas and lower source that happens with EUS guided approach. And we have treated cavities extending into bilateral pelvic paracolic gutters successfully using this technique, and really with excellent results in a lot of patients. Okay. So when indications for intervention for walled-off pancreatic necrosis include an infected necrotic cavity, patients with persistent organ failure, gastric, intestinal, or biliary obstruction, patients having persistent unwellness with abdominal pain, nausea, or vomiting. If you look at the data for lumen opposing metal stents in this population, overall, if you see, resolution is achieved in more than 85 to 90% patients. This is a study which I performed while I was at Mayo Clinic, where we compared the large caliber metal stents with plastic stents in patients with WOPN. Overall, resolution rates were similar between the two arms, but requirement for necrosectomy was much lower in the metal stent arm. The hospital days stay on an average was much lower in the metal stent arm. The safety of these stents has been called into question in some of the studies. And I think something that I personally feel a little more concerned about is bleeding. In our study, it was 5.4%. Now, we have done in the last year, I'd say about 50 odd patients with WOPN at Midas in Nagpur. And we have seen, I'd say 3 or 4 patients have a lot of bleeding, especially when the stent was kept in for longer duration. So now, over time, now we have changed our practice to remove these stents within 4 weeks. And this was highlighted in some of the earlier trials and studies as well. Mostly these patients do not have bleeding, but if you keep it for longer, that can happen. The data shows 5% in the study, which I did before, 7% and 1.6% in the other study. Risk of perforation is, I haven't quite experienced it myself, but it's quite low, 0 to 3%. Stent migration can be a problem. In our study in the US, this was 21%, but that was largely because the stents were for necrosectomy, because the endoscope was passed through the stents for necrosectomy. But this has happened to me a few times in the last year. But generally what we have done is during the procedure itself, redeployed the stent. So I'd say this has probably happened 3 or 4 cases in the last 50 I did in the last year. And what we basically do is just really redeploy the stent. So this really doesn't end up being an adverse event, except for like some patients in which you may have to send them for surgery if that stent can't be redeployed or get a new access point. Stent occlusion occurring 3 to 5% in various series. In my experience, this actually just happened once in the last 50 patients, so not really that frequent, I would say. All right, another just simple case, 70-year-old female with abdominal distension, pain 7 weeks post-lap chole. CT showed a large collection here near the hepatic parenchyma, and on MRCP, a large collection as you see here. Again, similar technique, we use EUS guided placement of a lumen opposing metal stent here. And in this case, we just dilated the stent, put double pigtail stents to prevent migration. And in this particular case, about 2 liters of bile came out of the post-op collection, suggestive of a biloma. So if you look at data for post-operative fluid collections, again, I don't think this has really gained a lot of popularity, but I think just to highlight that it can really be performed and can be a patient-preferred method just because there's no external percutaneous access. Patients don't have pain. In this series, average collection size was about 8 centimeters with technical success more than 90%, with clinical success almost 90%. Few adverse events, mostly stent migration, but nothing significant except say a case of perforation also. Pigtails can also be used in this particular series. Pretty good success. I think the advantage is obviously the cost. And I'd say collections in which there's no thick debris, pigtails can be a viable option. Technical success achieved in 100% in the series, clinical success about 94%. 4 patients had bleeding. Got to be careful not to avoid vessels when we're doing this. All right. Now, if you compare that with your traditional approach, which is percutaneous drainage, this is a meta-analysis published last year. No difference in technical success between EUS guided versus percutaneous drainage. If you compare the clinical success, superiority of EUS guided drainage versus percutaneous drainage, 93% versus almost 80% with percutaneous drainage. All right, let's move forward. EUS guided enteral access, as I showed you earlier, you have the ability to access the small bowel transgastrically in patients, or transduodenally small bowel in some cases. So this is a patient, 58-year-old male with chronic hepatitis C with cirrhosis, diagnosed with pancreatic cancer, presented with nausea, vomiting, with gastric outlet obstruction. Patient underwent duodenal stent placement, now presenting with recurrent nausea and vomiting. So just to show that the stomach is extremely distended and a metal stent, the duodenal stent is seen here. So in this case, this is something I performed during my training, actually during my, when I was working in the West. Patient, as you see, and in the enteral side, the tumor has infiltrated the duodenal stent. So we flush a large amount of methylene blue mixed with contrast and normal saline. And under fluoroscopy, you see the small bowel is nicely highlighted. All right. Across the gastric wall, we see nicely distended small bowel loops. And then we use this cautery-enhanced lumen opposing metal stent to gain access into the small bowel, which is a jejunal loop. And then we're deploying the lamps with the inner flange here in the small intestine, jejunum, right? And then on the gastric side, we see the other flange. All right. We place a guide wire to ensure that the stent doesn't migrate. Then we dilate the stent, as shown here. All right. And you can see through the endoscopic view the small bowel and the distal end there. All right. Post-procedure, patient had resolution of symptoms in 24 hours and was discharged in 2 days. So if you think about EUS guided gastrojejunostomy, what I showed you was the direct puncture technique. Can be a technically challenging procedure. So there have been some modifications available with the balloon-assisted technique. This is not really readily available. The EPAS, which is the EUS guided balloon-occluded gastrojejunostomy bypass, which is a special balloon created by Dr. Itoi from Japan, and this really makes it a lot safer, I would say. It's not commercially available in India now. Few centers have procured it. All right. So EUS guided gastroenterostomy, if you look at the meta-analysis, technical success, 92%, clinical success, 90%, adverse events rate of about 12%. So as we are evolving this technique and as there'll be refinement, this should go down over a period of time. So direct comparison of EUS guided gastrojejunostomy with enteral stent, overall much lower stent failure rate, higher clinical success rate. Comparing it with surgical GJ, open surgical GJ, no difference in clinical success, slightly lower adverse event rate, but not statistically significant. You compare it with laparoscopic GJ, similar to technical success rate, actually numerically a little lower with EUS. Clinical success was similar. Adverse events were lower actually with the EUS GJ arm in the study. All right, let's look at another case. 63-year-old male with obesity, diabetes, pancreatic cancer, status post-surgical gastrojejunostomy, chemoradiation, status post-Whipple's, presented with bloating, early satiety, nausea, emesis. EGD showed marked gastric food contents consistent with gastroparesis per records, but the labs showed elevated bilirubin, AST, ALT, and alkaline phosphatase. So if you look at the CT images, the small bowel is quite dilated, and you see there's a lot of pneumobilia here. So what this patient had was an afferent loop syndrome where the small bowel connecting to the gastrojejunostomy, which is the biliopancreatic limb, had occlusion, and therefore there is dilation, and then from there is obstructive jaundice occurring from the same. So in this patient, you see the gastrojejunostomy afferent limb. The scope was advanced to the afferent limb, followed by placement of a guide wire looped in that limb. And then we gained access across the EUS scope as in the outlined fashion before. Contrast is injected to confirm that you're in the in the afferent limb arm. And then under EUS guidance, the lumen opposing metal stent was placed successfully. And following this, patient's symptoms improved and LFTs improved over the next few days. So afferent limb syndrome has been treated successfully with EUS GJ in this 4-patient series with a 10 millimeter lumen opposing metal stent, with a successful placement in pretty much all the patients with clinical success achieved. All right. I'll just show you another interesting case. 56-year-old female with Roux-en-Y gastric bypass presented with right upper quadrant pain, fevers, Klebsiella bacteremia secondary to ascending cholangitis. And as you see on the cross-sectional imaging, the bile duct is diffusely dilated. So this patient underwent what we call as the edge procedure, in which we go, and just show here, we go across the gastric pouch into the the excluded stomach. This is post-Roux-en-Y gastric bypass. And the lumen opposing metal stent is placed here. Just to show you in the figure on the right, the excluded stomach is where you gain access via the lumen opposing stent from the pouch. And then the EUS scope was then advanced, the duodenoscope was advanced into the excluded stomach. And then using standard technique, ERCP is performed, followed by placement of a metal stent in the bile duct. So this patient did well, no complications. All right, so if you look at altered anatomy, ERCP, we have various options. Just to continue on the same topic, you can either do enteroscopy, which can be quite painful, as some of us have experienced in Roux-en-Y cases especially. It takes a long time to reach the ampulla. Oftentimes you may not reach. Laparoscopy assisted ERCP is an option, definitely much simpler and faster. Or you could do without any surgical intervention, EUS guided gastrostomy, which I showed you in the earlier case, followed by advancement of the duodenoscope into the duodenum and performing the ERCP. So let's look at the data. Overall, if you see enteroscopy assisted ERCP in different anatomies, 92% success rate here, and procedural success down to 81%. These are slightly high numbers. I think it's probably less than 90%, especially if you have Roux-en-Y patients. They have, say, 95%, but it's actually, quite frankly, much lower in most patients, most of the series. So if you see Roux-en-Y patients, enteroscopy assisted ERCP versus EUS guided gastrogastric fistula creation. In this study, 60% technical success with enteroscopy assisted ERCP versus 100% with EUS guided approach. Lower procedural time. The length of stay was much lower in the EUS arm, but adverse events was not quite different. All right, so let's move on. We'll talk about EUS guided biliary and pancreatic duct access and what sort of therapies can be done. This is quite exciting, and we've been doing a lot of these cases recently. So just as we talk about this, let's understand, when are we looking at this? This is not yet the primary modality for treatment for biliary obstruction. If you have accessible papilla, patients have ampullary pathology preventing passage of the guide wire in the bile duct. Periampullary diverticulum may make the anatomy difficult. Ampullary neoplastic infiltration. Patients who do not have accessible papilla may have, say, peptic GI stenosis, malignant GI strictures, GI bariatric bypass, altered surgical anatomy patients. Just as we talk about this, let's just briefly understand the terminology. Retrograde would mean the duodenoscope is advanced into the gut lumen, and any placement of stent is done through the papillary papilla or anastomosis. This is your regular stenting approach. We are going retrograde. It's endoscopic retrograde approach, which is our standard approach. Sometimes you can do antegrade approach, where you basically perform the entire procedure with the EUS scope. Stent is placed from the gut lumen across into the obstructed duct or across the anastomosis of the papilla, and I'll show you some cases. Or you can do transpapillary, where you get the stent across the papilla. Transanastomotic, where it's performed and placed across an anastomosis, say hepatico gastrostomy or pancreatico gastrostomy. Transluminal, where you're placing the stent across the gastric or the duodenal wall into the obstructed system. I'll show you a few of these cases just to highlight. So if you look at options for biliary drainage, you can go retrograde transpapillary, which means you gain access to the bile duct with EUS and then get a guide wire across the papilla and then perform ERCP with a standard procedure. Or you can go antegrade transpapillary, which means you're going across the bile ducts in an antegrade manner, not retrograde from ERCP. And then you get a guide wire across, and then you can place a stent either across the, you can place it across the papilla purely with the EUS without using the duodenoscope. You can either do hepatico gastrostomy, where you're placing a stent across a gastric wall into the bile duct, or you can do Colidoco duoderostomy, where you're placing the stent across the duodenal wall into the bile duct. All right, so just to show you some cases, 60-year-old male with history of alcohol abuse, pancreatitis, hypertension, hyperlipidemia, multiple comorbidities, presented with new diagnosis of gallbladder malignancy with metastatic disease, gastric outlet obstruction, and obstructive jaundice. So this patient had two obstructions, the gastric outlet obstruction as well as biliary obstruction. Now, with the gastric outlet obstruction, the papilla was inaccessible. So initially, a duodenal stent was placed right there, as you see. Stent's being deployed. All right. And then we performed a hepatico gastrostomy, where across the gastric wall, access was gained into the intrahepatic duct. See there. Contrast is injected to ensure that you are in the intrahepatic duct. And then the guide wire is coiled to ensure that the wire is nicely coiled in the intrahepatic duct. And then the metal stent is advanced across the gastric wall. And on the endoscopic view, stent is deployed in the gastric lumen. What's important to always note is that you need to have a fair amount of stent in the gastric lumen. And that's important because, right. So right there. That's important because with contraction, the stent can migrate out of the stomach, and that can be a catastrophic complication. So right there, as you see, the stent is nicely placed with a covered portion across the transgastric access site. We just dilated it and then placed a double pigtail stents to prevent migration. Post-procedure, patient had mild abdominal discomfort. Patient was discharged on IV antibiotics for a total of 3 weeks, likely from some bile leak that can occur in these patients. All right, so I'm just going to move to another case. All right, so this is another case here. The patient with an ampullary mass infiltrating the duodenal wall, and as you see in this video, we just could not make out the ampulla, and all the attempts to get into the bile duct were not successful using standard maneuvers. So what we performed was a EUS guided Colidoco duoderostomy. Across the duodenal wall, Doppler was used to ensure there were no intervening blood vessels. You see a fairly large bile duct. I use a 19 gauge needle. What you can also use is a Cook 19 gauge access needle, which actually prevents shearing of the wire. So here we get the guide wire placed nicely in the intrahepatic ducts. And then a cystotome is used. A 6 French cystotome was what I use generally to get access across the duodenal wall. And then a partially covered stent was placed with the proximal pouch portion in the common bile duct, and the distal portion, as you will see, right there. placed in the duodenal lumen. So there was excellent drainage of contrast and bile, and patients did quite well. Okay, so if you look at success and complication rates of Hepatico Gastrostomy and Colidoco Deuteronostomy, so this series overall success rate of 92% with transduodenal, that's Colidoco Deuteronostomy, 10% complication rate. For Hepatico Gastrostomy, slightly higher rate of complications, 18.9%, but success rate was equivalent of about 90%. Okay. So how do they compare directly to each other? Overall, there was no difference in the technical success between the two arms. Clinical success, a trend towards favoring Colidoco Deuteronostomy. Adverse events rates in this particular meta-analysis, there was no difference between the two arms. All right. How about EUS guided biliary drainage versus percutaneous biliary drainage? Technical success, no difference between the two arms. Clinical success favored EUS guided biliary drainage. Adverse events much lower in the EUS guided biliary drainage arm. What's new on the horizon is some of these taper tip dilators for Hepatico Gastrostomy access. For those interested in the field, these dilators not yet available in India, but I'm looking forward to having them because cautery can cause some problems, especially Hepatico Gastrostomy. So this particular study where they compared cautery dilator versus mechanical dilator, the adverse event rate was much lower in the mechanical dilator arm, with bleeding seen in none of the patients in mechanical dilation versus 6 of the 33 patients in the cautery enhanced arm. What else is new on the horizon is this needle that's not available in India, I suppose, but this is the needle which is with a curved with a tip that can be bent to enable access into the preferred duct to get the guide wire across. Overall technical success, 21 out of 22 patients. This is my colleague Marvin Drew from Harvard, who did the study with a pretty good success rate, 21 out of 22 with this needle. All right. 56-year-old female with rheumatoid arthritis, with renal amyloidosis, with ESRD, presented post-kidney transplant with biliary colic. Right upper quadrant showed cholelithiasis. Surgery team felt she has high risk for surgery, so discussed various options with the patient. Now, if you think about it, this patient is not going to get a cholecystectomy because of her high surgical risk. So PTC versus EUS guided gallbladder drainage was what we discussed. PTC can be performed, but then it requires frequent catheter drain changes. And then if you remove the PTC catheter, then cholelithiasis remains and the patient is still at risk of biliary colic and having complications. So patient preferred EUS guided gallbladder drainage, which is what we performed in this study, in this patient. Across the duodenal wall, the gallbladder is visualized, as you see here. And then a suitable avascular window is obtained. We generally make sure that the distance between the enteral wall and the gallbladder is less than 1 centimeter. Next, a cautery enhanced stent is advanced into the gallbladder lumen, and then followed by deployment of the flange inside the gallbladder, and then externally across the, I think the gastric wall in this particular case. All right. As you see, there is, well, so we dilated, we ensured, this is done under fluoroscopy guidance, and there's plenty of, a few stones in this particular patient inside here, which were removed with endoscopy. So if you look at EUS guided gallbladder drainage, which Lumen opposing metal stents, overall 90% plus technical and clinical success rate. Compared to PTGB, patients with EUS guided gallbladder drainage in this retrospective study had lower pain because you're going internally and there's no external catheter, reduced length of stay, reduced rate of re-interventions, and overall the adverse events were basically not too different between the two arms, actually lower in the EUS arm, I apologize, compared to the PTGB arm. Again, this is a hot off the press randomized controlled trial performed by Anthony Teo, published in Gut this year. EUS guided gallbladder drainage compared with percutaneous gallbladder drainage. Look at the technical success, excess of 95%. Only one patient, they couldn't do it due to blood vessels. Clinical success, excess of 90% in both the arms. But as I said, the analgesic requirements, the pain is much lower in the EUS arm because you're doing this across the enteric lumen. The one-year adverse event rates were significantly lower in the EUS arm, and re-intervention rate was much lower right there. So this largely occurs in the PTGBD because patients will need to get frequent stent exchanges. These are elderly patients. The stent, the catheters fall off. You remove the catheter, patients get recurrent cholecystitis. So therefore, preferring EUS over PTGB. All right. So just to show you something interesting, this is a patient with cholecystitis and cholelithiasis. We did cholecystogastrostomy. And then with the help of endoscope, as you see, there are so many dark black stones in there. We go across the gastric wall, and then now we are in the gallbladder lumen looking at various stones. So I spent about 1 hour clearing stones in this patient, and just show you the final outcome where we've used the Rothnet to get the stones out. And we had a container full of dark stones. All right. What else can happen in these patients? This is a patient, 82-year-old male with cholecystogastrostomy and had melena. So we went inside the gallbladder lumen. Initially, I'll just move forward quickly. Cholangiogram is obtained across the cystic duct. The duct looks patent and fine. And then on our way back, you see there's an ulcerated area in the gallbladder, mucosa here with oozing. So we went ahead and placed clips transgastrically into this area. All right, so let's move forward. Let's look at EUS-guided interventions in the pancreatic duct. So you can either go retrograde, that is transpapillary or transanastomotic. Again, as I showed you, we get the guide wire across the pancreatic duct or the anastomotic orifice, and with duodenoscope perform the regular ERCP. Or you can go antegrade, transpapillary or transanastomotic, where you basically do the whole procedure with EUS, get the stent placed across the papillar anastomosis. Or you can do transmural pancreatic duct drainage, where you're going across the gastric wall into the pancreatic duct and place the stent. So this is a case-based patient we did very recently on 22nd January, and I'll show you what we did in this case. So this is a patient with pancreatic duct leak with failed ERCP times 2. The patient had, as you see here, the peripancreatic collections which were walled off. There were several collaterals. We identified the pancreatic duct here. This is in the neck of pancreas, which is quite small. It was only 1.6 mm in diameter. And then in the pancreatic body, again, it's quite small. It's just 1.9 mm. So next we use a 19 gauge needle what can be used is the Cook 19 gauge needle, actually pretty good, as it allows you to move the guide wire. Here we get a regular 19 gauge needle across, inject contrast, shows us the pancreatic, that you're in the pancreatic duct. And then we advance a guide wire into the pancreatic duct quite nicely there. We use a Terumo guide wire initially, and then we switch to a regular 035 guide wire. And then we use a cystotome, a 6 French cystotome. First we get it across the gastric wall. Now this was quite challenging because, as you see, the pancreas was pushing away, and there is ascites in this patient. These, I would say, pancreatic duct interventions probably are more challenging than the biliary duct interventions, in my experience. And here we got, with some difficulty, the cystotome eventually across into the PD. And then we injected contrast, and we see there's leak in the tail of pancreas at the far end over there. So there was a leakage of contrast confirming the bile leak. And then we advanced a 5 French single pigtail stent across the gastric lumen. And eventually we got stent placed successfully right there. This is the endoscopy view, and you see the stents coiled across the gastric lumen now. Right there. So this is the stent in the gastric lumen going into the pancreatic duct. So this patient had mild pancreatitis post-procedure, but eventually, over the course of next 6 to 7 days, the pancreatic ascites reduced. He was eventually, now he's actually almost discharged from the hospital with a successful stent placement. Okay. Outcomes with EUS guided pancreatic duct stenting. Overall technical success ranging from 70 to 90%. Clinical success, similarly 70 to 90%. Patients can have some adverse events, risk of hematoma and bleeding, and perforation can occur. Well, this is because some patients can have bleeding, as if you're not careful, if you go across the gastric wall. And what you're using is cautery as well. But of course, if we, as and when we start using taper dilators, I think the risk should be much lower. All right. Fully covered stems have also been used for anastomotic strictures. I won't go into much details, but this has been successfully performed in patients. All right, I'll just move forward. And what else we have is the pancreatic cyst, the Moray forceps, applicable for cystic neoplasms of pancreas. As you know, the main problem is differentiating between mucinous and non-mucinous cysts, as if the CA is not within the range, then it can be a little hard to figure out. So this microforceps biopsy was compared with EUS guided FNA. Specific diagnosis could be achieved in significantly more patients with the microforceps biopsy, because it enables you to get tissue samples from the wall of the cyst. All right. So I would like to thank you all for logging in, and it's been a pleasure to give this talk, and I'll be happy to answer any questions. I think I have exceeded time, maybe a few minutes here, but all right. So Manoj.
Thank you so much.
Thank you so much, Dr. Saurabh, for an excellent lecture today on EUS applications. We are so privileged to have Dr. Shivdattapati, the consultant gastroenterologist at Medishine Hospital, Raipur, to moderate this session. So we can take a few questions. I think that would be perfect for you. Is the time is okay for you?
Yes. Yes, thank you, please.
Okay,
Yeah.
thank you. Over to you.
Perfectly fine. Hi, Shivdat, are you here?
You are on mute. Oh, yeah.
All right. Well, I can answer a question that I can see in the chat as Shivdat is logging in. So there's a question by NK Tarve. How long can we leave the lumen opposing metal stent for gallbladder drainage? All right. So I think so as far as how the duration goes, there have been patients in which it's been left for a long period of time. I personally would not favor that because of two reasons. One is there can be a risk of bleeding as the stent can erode into the blood vessels. And two is the stent migration, because oftentimes you place it across, say, the gastric antrum, which contracts, and then the stent can get migrated and get buried in the wall of the stomach. So it's fine initially, but if it gets buried, then it can be a nightmare to take it out. So what my practice is that I bring the patient back in 3 to 4 weeks. I remove the metal stent. By the time the fistula tract is nicely created between, say, stomach or duodenum and the gallbladder, and then we replace it with double pigtail plastic stents, 10 French or 7 French, to ensure that the tract is patent, so that the patient, even if there are gallstones in future, it doesn't lead to cholecystitis, because it provides you an outlet for the bile to get across the fistula cavity in the stomach. So I would say, by and large, by 4 weeks, take it out and replace it with plastic stents. That would be my preferred approach. Okay.
So what is your preferred approach for WPN?
Hi, how are you? Yes.
Yes, sir.
Okay. Yeah. So thank you for logging in. Yes. Hi. So when we have patients with walled-off pancreatic necrosis, I think what we have learned over time is endoscopic approaches overall have superior outcome to a surgical approach. One, if there's a large necrotic cavity, of course, I'm assuming there's an indication for intervention. If there's a large cavity across the gastric wall and you can get access safely and avascular way into the cavity, generally either I usually use the metal stents almost uniformly, unless I'm 101% sure it's pure water pseudocyst, then I can consider a plastic stent. But generally I use a metal stent. Now, if it's going in the paracolic gutters, we can mix it up with a percutaneous pigtail or a surgical drain. I have seen patients in which we have treated even paracolic extensions purely with a transgastric approach, but a percutaneous approach can be additionally needed. As far as the necrosectomies goes in these patients, generally, if there is source following procedure, I do necrosectomies, aggressively debride the cavity until the source resolves, patient's comfortable and almost afebrile, and then I discharge the patient. What happens is, even if, say, the cavity is not infected to begin with, you're introducing bacteria across the gastric wall and the cavity can get infected. And if you have pockets and recesses which are not drained, then they can get infected. So that's the reason why I do aggressively necrosectomies in these patients. I almost do that every 48 to 72 hours until the patient has no source, and then I stop doing necrosectomies.
So nice.
And sorry, last thing, by 4 weeks, I do not keep the stents for more than 3 to 4 weeks. Just a very important thing. Yeah.
So that is the take-home message before 4 weeks, the stent should be,
Right. Yes,
that
absolutely.
would be
I
right.
think most problems occur if they're larger than, greater than 4
Larger.
weeks if they're kept in this.
And for necrosectomy, sir, what do you prefer actually? Do you prefer hydrogen peroxide with cleaning of the cyst, or how? What is your approach?
So, hydrogen peroxide I used to use it initially. It's hard to tell. I don't know if there was really much benefit. There's no data to support it. And in fact, some people have cautioned against the use of it. So I have personally moved completely away from hydrogen peroxide. I don't use it now at all. Whether we put nasocystic drains or not, some patients we do, others we don't. No more necrotic debris. We have put. I'm not convinced it makes a big difference, but certainly doesn't hurt. The problem is once you use the nasal cavity, then nasojejunal feeding, if you need to do, can not happen because you already have a nasocystic drain. So that's true. And as far as the instruments go, I've started using snares more recently. You have to be careful, but that's now something that I've liked to use. Initially, I was using more rat-tooth forceps and Rothnet, but I've used to snares. Yeah.
Okay. That's nice. And sir, any more comments on US guided coil and glue for fundal varices? Where what is your take on? Because that is one part. Maybe we can be more. Maybe a little more, light can be shed.
No, totally. I think I was supposed to. I think something happened. I was supposed to show you the EUS guided fundal varices case. So actually, if you don't mind, I'm going to quickly show you a case briefly. Let's see. So yeah, I'm myself quite interested in this. We have done cases with success. Just give me 1 second.
Absolutely, sir. Take your time.
Okay. Okay. I think I don't have that on me.
No problem.
But anyway, so as far as US guided coiling of the gastric varices goes, overall, less amount of glue is needed. So your risk of embolization is lower when you combine coils with glue. Two, it's a safe procedure. Risk of complications is, not really much more than a regular glue injection, actually lesser than glue injection. We use a 19 gauge needle. For this, the ones available in the market are the ones from Cook, and they just go through the Cook needle. They don't go through the other needles. So if you have to use the Cook needle, because I've tried it in other needles and they just don't go across. So that's something as a word of caution. Anyone plans to use it, you'll end up wasting a coil and a needle if you don't do it the correct matching. And as far as the procedure outcomes and success go, the technical success has been in the range of 95% and above. Clinical success rate also in the similar range with lower complications than direct glue injection. And the only added advantage, which I feel, is one, you're comfortable, you're actually inside the vessel. And two, even if there's a large amount of bleeding and a lot of blood in the gastric lumen, you can actually visualize and confirm the presence of the needle inside the gastric varices. Yeah,
That's right. So what do you envision endohepatology as a branch or maybe as a subspecialty coming up? With 25 gauge needle, monitoring of hepatic vein pressures, portal pressures. How do you see it, growing?
Well, I think number one is, in terms of the ability, us as endoscopists and people, primarily doctors managing these patients, it's a great tool because it's in your hand, it's safe, and if you can, you're managing liver patients. During one-stop shop, patient comes in, you can sedate the patient, you can do portal pressure measurements, you can do liver biopsies, you can do variceal banding, all of it in one go. So that's number one. Number two is we currently, if you see most the practices do not do any further tailoring of portal hypertension management. So it's pretty standard. Patients on beta blockers, getting variceal banding, that's it. Now, now your beta blockers and variceal banding, despite that, all of us have seen patients come in with bleeding, right? And largely if their portal pressures are persistently high. Now, we don't actually actively manage the portal pressures in these patients, right? You have a patient with regular systemic hypertension, you manage that. You don't just start a patient on a medicine and go home. You manage it, you increase the dose, you get it under control to prevent adverse events. We are not doing that right now. So if we start doing that, then we will be able to achieve superior outcomes in our patients, because now we'll be actively tailoring the portal hypertension management to ensure that the pressures are at targeted range, number one. Newer therapies, you want to use statins in combination with beta blockers, you'll be able to determine if there's any improvement in portal pressures. Patients, despite everything, high pressures, you may want to consider doing a TIPS in these patients. So it really enables you to more effectively manage these patients. That's my take on it. Yeah.
So nice. Any more questions? Maybe.
All right. All right, Manoj, I think it's.
Thank you, Dr. Saurabh.
Thank you so much, both of you, having a wonderful lecture tonight, and it must be, I think, deeply discussed. Thank you so much for your, the presence here, Dr. Shivadatta, to support, moderate the session, and all the people, everyone, those who are joined here for this this lecture. Thank you so very much, and good night.
Great. Well, okay. Thank you.
Thank you, Saurabh sir, for such a wonderful presentation, and we learned a lot. And we hope for more interactions with you and to get your take on issues. Thank you so very much. Thank you.
Shivdat.
Have a nice
thank
day.
you.
Thank you, sir. And thank you.
Thank you so much.
Thank you so much. Have a nice day. Thank you. Bye. Thank you.
Okay.
Thank you.
All right. Is it recorded, Arpit, all this? Okay.
Yes, I have recorded. Yeah.
All right. So thank you. If you don't mind, can you send me the link? That'll be nice.
Sure, I will do that. I will do that. Thank you.
Thank you so much, guys.
We'll be ending here. Thank you so much.
It was a wonderful presentation. Thank you. Thank you.
It's nice to see you. Hope to see you in person next time.
Thank you.
Great. Thanks.
Thank you.
Thanks.
Thank you.
Thanks.